So good morning everyone and welcome to this session on free paper and cornea. First paper is fibrin glue, the latest alternative for corneal perforation sealing. Presenting author is Vanshika Khanna. Is she here? Next paper by Dr. Mugundan Rajarajan. Come. So this is the topic is microsporidia stromal keratitis co-infection, challenging scenarios.
So I'll start. So very good morning everyone. So I'm Dr. Mukundan Rajarajan. I'll be taking you through 3 cases of microsporial stromal keratitis which has an unusual presentation and had challenges in management. All 3 patients had co-infection. So starting with the case 1, a 62-year male from Visakhapatnam who is a known case of rheumatoid arthritis on immunomodulatory therapy, present to us with symptoms in the both eye for the 5 days. On examination, he had right eye epithelial defect with ill-defined anterior to midstromal infiltrate that has granular appearance and SPKs. In left eye, 2 focal area of cellularity were noted. Scraping done which showed oval-shaped microsporidia along with gram-negative bacilli. So patient was started on ofloxacin hourly along with voriconazole eye drops hourly. On subsequent follow-up, there was increase in epithelial defect size and infiltrate noted with presence of lot of chemosis. So there was a dilemma whether there is a toxicity of medication versus infection. So repeat scraping was done which revealed only oval-shaped microsporidia. So patient was continued only on topical and systemic voriconazole. On subsequent follow-up, there was consolidation of infiltrate noted with the descemetocele formation for which TA-BCL was done. And in subsequent follow-up, the descemetocele epithelized and the infiltrate healed with dense scarring and vascularization. Moving on to case 2, a 38-year female with complaints of redness, pain in the right eye for the past 1 month. There was no history of any trauma, history of similar episode in the right eye 5 years ago. On examination, vision in the right eye was 20/50 with presence of midstromal edema and infiltrate and KPs on the endothelium. So diagnosis of HSV keratouveitis was made and patient was started on oral acyclovir along with topical steroids. On subsequent follow-up, the midstromal infiltrate was persistent and more denser. So in this visit, we had clinical suspicion of microsporidia. Corneal scraping revealed no organism. Hence, a corneal biopsy was done and a sample was sent for IFA PCR. So scraping revealed oval-shaped microsporidia. So for this patient, we start on PHMB and chlorhexidine eye drops along with systemic oral albendazole. So on subsequent follow-up, she developed epithelial defect with stromal infiltrate appearing more denser. The IFA and PCR came positive for HSV. So a co-infection along with HSV was considered and patient was started on oral antiviral also. So subsequent follow-up, that infiltrate became more denser and antral lens capsule involvement was also noted. So planned for therapeutic PK. So 9.5 mm graft was used and intraop lens involvement was noted. And after 2 weeks, patient was started on topical steroids and she is doing well with a best corrected visual acuity of 20/80. So moving on to case 3, a 52-year male with complaints of blurring of vision, redness, pain for the right eye for the past 3 months. He's been on antifungal medication for the past 3 months. On examination, vision was hand movements with presence of large epithelial defect along with infiltrate with a inferior paracentral perforation for which a corneal scraping along with TA-BCL was done. A corneal scraping revealed the presence of oval-shaped microsporidia along with septate hyaline fungal filaments. So diagnosis of microsporidia plus fungus co-infection was made and patient was started on antifungal and eventually ended up in therapeutic PK in view of deep microsporial infection. So corneal button grew aspergillus flavus. There was no recurrence in 2 weeks and patient was started on topical steroids. The half corneal button also showed presence of fungal filaments along with the oval-shaped microsporidial spores. They are better appreciated in the image C and D. Image C is a GMS stain where a fungal hyphae are seen as a black thin hyphae, whereas the image D is a Quignon stain where a bright red oval microsporidial spores are noted. Thus, in conclusion, microsporial stromal keratitis is a rare entity. Literature search, we found very few case reports of co-infection with microsporial stromal keratitis. Most of them were associated with viral and bacterial co-infection. According to our knowledge, there is no case of microsporial stromal and fungal co-infection reported in the literature. Thank you.
I call upon the next Dr. Pankaj Dongre. Central toxic keratopathy post collagen cross-linking.
Yeah, good morning everyone. So my free paper topic is central toxic keratopathy post collagen cross-linking. So we have been known that collagen cross-linking is a effective procedure for halting the progression of the keratoconus. But we also know that there are some complications related to collagen cross-linking, especially microbial keratitis post CXL, the haze, reactivation of herpetic keratitis, and various the microbial infection. So CTK is one of the sequelae of collagen cross-linking which has not been reported yet. So there is no financial disclosure in my presentation. So the purpose of this study was to report a case series of central toxic keratopathy following collagen cross-linking in keratoconus. So it was a retrospective case series which was done, which included the patients who had underwent CXL for progressive keratoconus from January 2020 to September 2021, and we included, we have done CXL for about 964 eyes in this period, and the protocol which was used was the epithelium of accelerated protocol. The cross-linking system, the machine which was used was the Avedro KXL cross-linking system. As we have used the accelerated protocol, we have given the riboflavin soak time of 20 minutes along with UVA light exposure for around 10 minutes. After the procedure, the BCL was applied and it was kept for around 1 week along with topical low potent steroids in a tapering dose for over 4 weeks, along with topical antibiotics for 1 week and topical tear substitutes. Out of the 964 patients, the 12 patients were noted to develop CTK. The age group were of all the patients were between 16 and 32 years, and there was no any sex predilection. Equal number of males and females were noted. So this is a table which shows all the patients. The interesting thing which we can see here is like all the patients, they presented within 1 week of the after the CXL. They all had the characteristic features of CTK, which I will be discussing in my subsequent slides. So at 1 week, this patient presents with this kind of clinical picture where we can see there is stromal opacity which is central in location. You can see there is no any congestion on the conjunctiva, and also we can see there are striae which are radiating from this opacity. The striae are nothing but the folds in the Bowman's membrane. The same picture in the slit image. As I told, all the patients, they presented within 1 week. They had the central dense stromal opacity. No opacity was noted in the periphery. It was localized. The margins were very distinct. There was stromal thinning under this opacity and the presence of striae. As you can see in the ASOCT picture, the opacity was more in the anterior stroma, and as you go towards the posterior stroma, the density of the opacity and also the area of the opacity was decreasing, and it also shows a very characteristic inverse dome shaped pattern. When we performed corneal topography in these patients, what we found out interestingly is that so this is the pre-op topography where K1 K2 is noted around 45 and 51, whereas at 1 week the cornea became flatter. K1 became to 43 from 45 and K2 became around 47 from 50. So there was flattening in the cornea. The confocal microscopy performed at this visit at 1 week shows no any inflammatory cells, but there were activation of keratocytes. As we followed up these patients, this is the example of one such patient. We can see at 1 week, 1 month and 6 months, the density of the opacity decreases. There were striae, and also the ASOCT shows the inverse dome shaped pattern, and you can see just below the stromal opacity there was thinning of the corneal stroma. Again, this is the graphical representation which shows that in the acute phase of the CTK, there was corneal flattening, but in the remodeling phase the cornea became little bit stiffened, but the stiffening was not more than which was there in the preoperative level. That means the cornea regained its structure but less compared to the preoperative level. Same in the Kmax. The pachymetry, you can see there was thinning in the acute phase of the corneal stroma. So CTK, as we know, it is a acute non-inflammatory self-limiting condition which is most commonly seen after post-laser refractive surgery, commonly seen after LASIK, and it is associated with, as I have shown, central corneal opacification with stromal tissue loss along with striae. And as there is stromal tissue loss, there is significant hyperopic shift in these patients. Interesting thing is there is no case, this has not been reported after cross-linking. This is the mechanism how the hyperopic shift occurs, because there is loss of stroma, the anterior surface falls back and fills the gap, thereby causing flattening of the anterior surface of the cornea. So these are the probable external factors which play a role in the formation of CTK, maybe the meibomian gland secretions, marking pen ink, the talc from the surgical gloves, or the photoactivation of povidone iodine by the excimer laser. As we can see, the density decreases over the time. It's a self-limiting condition. We need not to intervene actively in such. This is the again topography which shows at 1 year the cornea again remodels, but the steepening of the cornea is always less compared to the pre-operative level. Same thing with the ASOCT. So as I told, as the disease, there is remodeling of the cornea and there is reduction in the hyperopic shift.
Time is up.
Yeah, thank you.
So how long did you follow up the cases?
Yeah, so few of the cases they follow up till 1.5 years. By 1.5 years, the opacity fades away. Yeah, 18.
What's
Thank
the
you.
one test you will tell to distinguish between stromal haze post C3R and your CTK? One test.
ASOCT, because ASOCT will show a demarcation line in case of post CXL haze, whereas there is no any demarcation line in CTK. It gives a characteristic inverse dome shaped pattern.
Thank you, doctor.
Yeah, thank you.
Next, Dr. G. Divya. She'll be presenting on hitting the bullseye, role of intrastromal voriconazole injections in deep stromal fungal keratitis.
Good morning everyone. I'm Dr. Divya from Visionary Eye Hospital. My topic for presentation is hitting the bull's eye, the role of intrastromal voriconazole injections in deep stromal fungal keratitis. The scope of the presentation includes introduction, the procedure of intrastromal vozole, study, and the conclusion of this study. Mycotic infections are responsible for nearly half of the cases of culture positive infections in developing countries. TST protocol provides a systematic treatment algorithm for fungal keratitis with variable severity. Initially, we start with a topical netamycin or voriconazole, and we add systemic antifungals if the size of ulcer is greater than 5 mm or if the depth is greater than 50% and if there is any impending perforation. And if the ulcer doesn't respond to the above, then we go for targeted therapy in the form of intracameral and intrastromal antifungals. But still, deep stromal keratitis poses a challenge as there are several limitations of currently available topical medications like poor penetration, surface toxicity, and limited spectrum, which lead to non-healing ulcer, finally landing up in keratoplasty, which is limited by factors like graft rejection, reinfection, and limited availability of donor corneas in our country. So targeted therapy in the form of intrastromal antifungals form a depot of drug around the ulcer, helping in better healing, thus avoiding the need for keratoplasty. So in this study, we have given intrastromal voriconazole to treat deep fungal keratitis. This is a prospective interventional case series conducted at Visionary Eye Hospital, Visakhapatnam from August 2022 to August 2023. 8 cases of microbiologically proven fungal corneal ulcer that did not respond to conventional therapy over a period of 2 weeks were included in this study. And depending upon the severity, patients required multiple injections sequentially, and the patient was followed up for every 5 days, and healing was documented using a slit lamp imaging. Coming to the procedure, vozole as a preservative powder, lyophilized powder, is available in a glass slide 1 milligram, and it is reconstituted with 2 ml of distilled water to reach a final concentration of 50 micrograms per 0.1 ml, which is then loaded in 1 ml tuberculin syringe with a 30 gauge needle. This is a video showing the procedure. The needle is entered with a bevel up from uninvolved area to the corneal ulcer at the mid-stromal level, and the drug is injected. The amount of hydration is used as a guide to assess the area involved. Once the amount of drug is delivered, the plunger is withdrawn to break the capillary column. 5 divided doses are given around the ulcer, which form a barrage of intrastromal antifungal around the ulcer. So these are the results. We have given intrastromal ozol in 8 cases. The age ranging from 17 years to 60 years, and out of 8, 6 are male and 2 are female. Majority of cases are mid to deep stromal, who required multiple doses sequentially. Among 8, 6 healed well with good visual acuity improvement, and 2 underwent therapeutic penetrating keratoplasty. So intrastromal voriconazole comes under targeted drug delivery. It is a safe and effective way to treat deep recalcitrant fungal keratitis, thus reducing the need for therapeutic penetrating keratoplasty. This is a slide showing pre and post injection pictures. Thank you.
Did you find the species or anything, like what you are getting, like which type of fungus you are getting in all those 8 cases?
Aspergillus and fusarium.
I think case 1 was your worst case, no? Did you have any photographic documentation of that?
Last 2 cases are worst cases, ma'am, like increased.
Can you go back to that slide?
Yeah, yes. That is in the central area, so once the...
Thank you, doctor. Next, Dr. Soumya, Pythium keratitis, battling the dreaded pathogen.
Good morning, one and all. I'm Dr. Soumya Vegesna, Cornea Fellow from Visionary Eye Hospital, Vizag. Today I'm going to present you about the Pythium keratitis, battling the dreaded pathogen. So, my topic covers the scope like background, study, description and results, and conclusion. So background, Pythium insidoism is an oomyosite and is closely called parafungus as it closely mimics fungal keratitis. So the classical clinical features of Pythium that distinguish it from other microorganisms are reticular dots, tentacular projections, peripheral furrowing, early limbal spread, which require a high incidence of clinical suspicion. The picture A is showing a central dense infiltrate with tentacle-like projections extending to the periphery, and picture B and C show a dense white infiltrate with multiple dot-like para-infiltrates extending from the main infiltrate, and also there is peripheral furrowing from 2 o'clock to 4 o'clock position along with a hypopion of about 1 mm in size. Smear and culture. The slide A shows the culture plate of Pythium insidoism, and also Pythium exhibits morphological and microbiological resemblance to fungus on routine smearing, revealing perpendicular or obtuse septate or aseptate branching hyphae. And also in slide C, we can see the septate or branching hyphae which is resembling the fungal keratitis. So my study design is case series, and the purpose of my study is to elucidate the clinical presentation, management and complications of Pythium keratitis. Methods. 2 cases of Pythium keratitis were included in my study after microbiological evaluation, detailed slit lamp examination, corneal scrapings and microbiological evaluation. So the results of my study, this is a case 1, a 40-year-old male presented to our OPD with history of fall of dust in the right eye, and he complained of redness in the right eye along with severe pain, watering and discharge. So first is the initial presentation with a central dense white infiltrate of about 5 into 5 mm in size with tentacle-like projections extending to the periphery. Despite giving maximum medical and maximum medical treatment and systemic therapy, there is no improvement in the condition of the infiltrate. So we went for therapeutic penetrating keratoplasty, and this was a picture of post-operative day 1 keratoplasty. Initial presentation, the vision was only HM hand movements positive with no improvement with pinhole, and after post-operative 2 weeks, the infiltrate was almost decreased, and also cornea is relatively clear with best corrected visual acuity improved to 6/9 parts. This is the case 2, a 45-year-old male presented with history of injury with stick 10 days back, and he also presented with same complaints of severe pain, redness and watering in the right eye. And also there was infiltrate with about 6 into 6 mm infiltrate with peripheral furrowing and gutte-like appearance, along with hypopyon of about 1 mm in size. In spite giving maximal medical therapy and also systemic therapy, there was no improvement in the condition of infiltrate. So we went to therapeutic penetrating keratoplasty, and this is a picture of post-operative day 1, and also the post-operative 2 months picture showed relative decrease in the infiltrate and also relatively clear cornea, and the vision improved to 6/12. So both the cases had favorable clinical outcomes in eliminating the infection from the eye. So conclusion, when a diagnosis of pythium keratitis is made and maximum medical therapy is given, and if they do not respond in 2 weeks time, we should not hesitate in going ahead with therapeutic keratoplasty, as delay in this critical intervention can weigh against the favorable outcomes. These are my references. Thank you.
How did you know it is pythium? The
So
question
based
is
on
because clinically when you see it looks more like a fungal, what I mean.
Yes,
So it's
sir.
very difficult to get cases.
Yes, sir.
Understand?
Based on the morphology, sir, there's more dense infiltrate with peripheral gutterous presence. Sir. Yes, but in spite giving maximal fungal treatment for about 1 week or 2 weeks with topical antibiotics and also topical antifungals and systemic antifungals, there was no improvement. So we went.
Start on linezolid and other agents.
Yes, so we started on linezolid, azithromycin, and voriconazole, natamate, and doxycycline, but there was no improvement.
So you did the scraping by sending, or your button you had sent for the?
No, so we did the local scraping, and then we didn't send the button for the culture.
Are there any other studies similar to yours?
There are a couple of studies, ma'am. Even they show even the final intervention was therapeutic penetrating keratoplasty in those studies also.
Thank you, Dr. Next, Dr. Sudhakar Naidu Laveti, cure film osmolarity as a diagnostic tool in microbial keratitis.
I have uploaded there.
Can we have Dr. G. Divya, role of anterior segment OCT in diagnosing deep fungal keratitis?
One more presentation. No, second one. Good morning, everyone. I'm Divya from Vision Eye Hospital. My topic for presentation is role of ASOCT in diagnosing deep fungal keratitis. The scope of the presentation are background, role of ASOCT in diagnosing deep fungal keratitis, study, and the clinical relevance of the study in our practice. Infectious keratitis is one of the important causes of corneal blindness in our country. There are many kinds of pathogens that cause corneal infection, so the clinical manifestations are complex and diverse. So it's very important for early, rapid, and clear diagnosis for an effective treatment. Traditionally, infective keratitis is diagnosed using smears and culture. But however, these tests are invasive and cannot be performed in deep-seated infections, especially with an intact epithelium. So in recent years, endothelial plaque caused by infective keratitis have gradually attracted the attention of ophthalmologists. Endothelial plaque is a characteristic sign of fungal keratitis. However, other infective keratitis like bacterial also show endothelial-like plaque due to deposition of fibrin. But on slit lamp examination, due to corneal edema and the infiltrate present in front of endothelial plaque obscures the view of endothelial plaque, making it difficult to distinguish fungal from other infective keratitis. And also in these deep-seated keratitis with endothelial plaque, scraping cannot be performed as material is inaccessible. So it is important to find other examination methods to observe this endothelial plaque. In this study, we have used ASOCT to study the characteristic features of fungal keratitis with an endothelial plaque and to differentiate it from other infective keratitis. It is a prospective observational case series conducted at Visionary Eye Hospital from December 2020 to August 2023. 4 cases of deep fungal keratitis with an endothelial plaque and with an intact epithelium where smears and cultures cannot be performed were included in this study. ASOCT with a corneal module attachment in cornea cross-section line mode is used to evaluate the boundary between the endothelial plaque and corneal endothelial cells. So these are the results. Among 4 cases, 3 are male and 1 is female. 3 had history of injury with vegetative matter and 1 had history of fall of unknown foreign body. 3 underwent therapeutic penetrating keratoplasty and 1 resolved with targeted therapy. And all the 4 cases showed unclear wavy border between the endothelial layer and endothelial plaque. So these are the slides showing the clinical and ASOCT where the border is wavy between the endothelial cells and endothelial plaque. So conclusion of this study, in fungal keratitis there is an immune reaction to the penetrated fungal hyphae which results in production of the endothelial plaque, which shows wavy and unclear boundary in ASOCT between the endothelial cells and endothelial plaque. So clinical relevance of this study, so ASOCT can be used as a non-invasive diagnostic tool in diagnosing and differentiating fungal keratitis from other infective keratitis by observing the border which is wavy and unclear, hence helping in timely treatment, especially in cases of deep-seated fungal keratitis with an intact epithelium. Thank you.
Differentiate between a bacterial and this one, like ASOCT. In all cases of fungal, you are getting the same features. What you are getting.
So we have done only for fungal keratitis, sir. And 2 cases of bacterial where the border is, it's not a wavy, it is a clear border between the endothelial plaque and...
So can you stamp that what you are doing is how correct it is?
So actually we have done TPK in 3 cases. 1 there is no growth and 2 cases showed fungal cultures.
Don't have many cases, what I mean to say. Hardly or 7 or 4 or
4
5
cases. The limitation of the study is
so
the
what I
smaller
mean to say
sample.
can you stamp, like suppose you are doing 20, 30 cases and getting the same findings, that may help, what I mean.
Yes, sir.
So keep doing the study and write a paper on that.
Yes, sir. Sure, sir.
Which version of the anti-segment OCT were you using?
We have NIDEX, NIDEC.
If it's showing a heat map, that also helps you to analyze.
Okay.
You can try an image analysis nowadays. A lot of engineers are looking at images and allowing pixel analysis. So
Okay.
that would be a good
Okay.
Dr. Sudhakar Naidu Lavati
Thank
is
you.
ready. Please come and present on tear film osmolarity.
Good morning to all. I am Dr. Sudhakar. I am going to present a tear film osmolarity as a diagnostic tool in management of microbial keratitis. And there is no financial disclosures for the content of this talk. And tear film microbial keratitis is a major global cause of visual impairment and blindness, especially in rural areas of India. And proper diagnosis is important to detect the causative organisms so we can give the successful treatment. And awareness and access to microbial keratitis is very limited in our cities and not universally available also. So a role of point of care test is very important for a proper diagnosis and successful treatment. Brief discussion about tear film osmolarity. Tear film osmolarity is an index of the tear film dynamics and it is determined mainly by the electrolytes of the aqueous phase of the tear film and with some minor contributions from the proteins and sugars. Normal tear film values are 290 to 305 milliosmoles per liter. Anything below 300 is normal only, and above 300 is the disruption of the tear film. Coming to hypothesis, the fungal invasion of the corneal stroma upregulates the cytokines and matrix metalloproteinases. These cytokines and matrix metalloproteinases increase the tear film osmolarity, and also there is morphogenic switching of the yeast to hyphae. When compared to bacteria, the fungi are larger in size, so there is more inflammatory response in the bacterial and other infections. This cytokines and MMP9 upregulation results in increase in tear film osmolarity. The aim of this pilot study was to evaluate the diagnostic value of tear film osmolarity in diagnosing and differentiating microbial keratitis caused by the bacteria from the fungi. Methodology: total 42 cases were included in this study, and they are grouped into two groups caused by bacteria and fungi. And T film osmolarity test was done 2 hours after the confirmation of the causative microorganism by smear examination. Why the 2 hours is needed is if you apply any medications before 2 years, it will alter the osmolarity values. That's why after 2 years we have to do the test. And one more thing is, if the patient is dilated or if you put anesthetic drop, at least 15 minutes duration should be there. After 15 minutes only you have to do the test, otherwise the osmolarity values are not accurate. This osmolarity was checked with tear lab equipment, and the osmolarity values were noted and grouped into two according to bacteria and fungal infections. The brief review of procedure: first, this T film osmolarity kit contains the test kit and test pen as well as tear film osmolarity system. First, we have to attach the test card to the tear film osmolarity pen, and successful attachment is indicated by the green light. And after attaching this one, we have to remove the protective sleeve. And after removing the protective sleeve, ask the patient to look up and in. So then place the test card just nearer to the lateral canthus without touching the sclera. So it will automatically, the test card automatically absorb the tears, and it show the values. So the successful absorption is indicated by the click sound. And after absorption, we have to keep we have to dock the test kits on the tear film osmolarity system, and within 40 seconds of obtaining the tear film. And the test card has numerical values. After docking it onto the osmolarity system, we have to enter the correct numerical value. Then only it will show the correct reading. And within few seconds, the osmolarity values are displayed on the screen. This is the brief overview of the procedure. Now coming to results, the group A having bacterial keratitis has 22 cases, and group B have fungal keratitis 20 cases, and age and sex were equally distributed between the two groups, and we used one-way ANOVA calculator to compare the results to differentiate the osmolarity values between bacterial and fungal infections. And in all the cases, there is consistently higher osmolarity values in fungal infections when compared to bacterial infections, and the p-value also significant. Coming to conclusion, the tear film osmolarity values are consistently beyond 320 milliosmoles per liter in all the cases of fungal keratitis, except one case. That case has severe dry eyes, also associated values. And diagnostic value and it is also useful for diagnostic value and differentiating infections between bacteria and fungi. The limitations is we need to have a larger sample size to add value to our conclusion. But when compared to other studies they done the tear film osmolarity values only in dry eye cases, but this is one of the first few studies explore the role of tear film osmolarity in microbial keratitis. The limitations of study is no control group array because of high expenses, and the sample size is also small, only 42 cases. The strengths of the study are no other studies in literature explores the relation of this diagnostic value in microbial keratitis. There is a good potential of point of care test for general ophthalmologists. These are my references. Thank you.
I think without a control group of the other eye, the high values or low values actually don't.
But normal values, we are comparing with the normal values.
Lewis, you have written microbial keratitis, and most of the studies are done in fungus.
Yes.
So that's what madam is telling, like the comparative group. Normal group, then
Even
you
the
can
other
take,
eye actually they would have tested and said that
correct.
okay, this is higher than that.
Yes. Comparison with the other eye control should be required.
Yes.
You can change the study to a control group.
Control group, yes, sir, definitely.
We call upon Dr. Purnima Tandra, clinico-microbiological profile and treatment outcomes of actinomyces odontoliticus keratitis.
Good morning everyone, I'm Dr. Purnima. Today I'll be presenting the clinico-microbiological profile and treatment outcomes of actinomyces keratitis. So actinomyces are true gram-positive bacteria that are facultative, anaerobic, non-sporing and non-capsulated non-acid fast filaments. In culture, they form like a branched network of hyphae, hence it is also called as ray fungus. They are soil organisms often found in the decaying organic matter. It is primarily a commensal microbe found in a normal oral cavity, in tonsillar crypts, dental plaques and carious teeth. So there are very few case reports that have been presented before. One is a case of indolent infection following penetrating keratoplasty with a classic appearance of infectious crystalline keratopathy. It was not recovered from the corneal scrapings or culture, but the histopathological diagnosis was made in this case. And there was one more case report with a delayed onset of actinomyces keratitis post LASIK procedure also, in which there was an infiltrative patch at the flap stromal interface and it was diagnosed microbiologically. So the need for the study here is that most of these cases resemble fungal keratitis. We'll see it as we proceed, and they have been treated as fungal keratitis initially in multiple circumstances, and there is a difficulty in identifying the organism microbiologically because it often mimics other organisms like nocardia, and there have been very few case reports. Coming to the aim of our study, we plan to analyze the demographic data, predisposing risk factors, ulcer characteristics, antibiotic susceptibility and treatment modalities, and outcomes of all the patients with culture-proven actinomyces odontoliticus keratitis. It was a retrospective case series. We analyzed the electronic medical records of all the patients with culture-proven actinomyces keratitis between January 2017 and December 2021. So a standardized protocol was used in collecting the data for analysis. Coming to the demographic data, we had 9 cases of actinomyces keratitis, among which all were males. There were no female patients. And the age distribution, most of the patients, that is 6, were above 50 years of age group, 3 in 50 to 60 and 3 among 60 to 70 age group, whereas 1 each of less than 30, 30 to 40 and 40 to 50. So the predisposing factors that we analyzed in our study were history of fall of dust or soil in the eye as given by the patient in 45% of the patients, and a history of trauma with vegetative matter was found in 22%, and there was history of post PK in which the infiltrate was in the graft in 22% of the patient, and the patient didn't give any relevant history in 11% of the cases. So coming to the ulcer characteristics, the mean ulcer size was about 13.99 to 14.55 square mm, with the maximum size of the ulcer being 64 and minimum of 1 into 2 mm, that is 2 square mm of area. Coming to the clinical features, these are 4 among the 9 cases that presented at our center. So as we can see, they either present as white grayish infiltrates with feathery borders. They are like plaque-like and slightly more defined lesion. There is also presentation with hypopyon, and there are endoexudates in one case where it is presented post PK. Actually, this is a very old graft, 5 years after the PK. So all these clinical features also resemble clinically fungal type of infection. So we did corneal scraping, sent for smear examination and cultures. We have sent chocolate agar, blood agar, SDA and PDA. So based on the antibiotic susceptibility, 34% of the cases were susceptible to ciprofloxacin, 22 to fortified cefuroxime, 22 to amikacin, moxifloxacin and gatifloxacin were 11%. So the ulcer, we have taken time from presentation to macular scar formation. So it was a mean of 41 days. Summarizing, there were 9 patients which were identified. Risk factors were trauma and failed graft. Most of them were white and had a dry looking appearance. All were most of them were sensitive to amikacin and ciprofloxacin, followed by moxifloxacin, and 7 cases healed with medical management with a mean of 41 days. So this study is to re-emphasize the fact of need for microbiological examination in all the cases, even though there is a clinical appearance of fungus. Yeah. Thank you. Thank you.
Thank you, Doctor. Dr. Sudhakar Naidu Lavati on tacrolimus 0.1% as an alternative to loteprednol 0.5% in management of nummular keratitis.
Good morning to all. I'm going to present tacrolimus 0.1% as an alternative to loteprednol 0.5% in nummular keratitis cases. There is nil financial disclosures for the content of this talk. The main motto for my study is a 40-year-old vascular surgeon who came to our hospital with both eyes nummular keratitis, having 636 partial vision in both eyes. We started on loteprednol 0.5% eye drops, only 3 times a day.
Tech team slides are not coming.
Okay. Color change. So the main motto behind my study is 40-year-old vascular surgeon came to our hospital with 636 vision and both eyes nummular keratitis. We started on loteprednol 0.5% eye drops 3 times a day, and after 2 weeks he came with pain in both eyes and IOP was 35 mm of Hg, and we replaced it with tacrolimus 0.1% eye ointment 2 times a day for 2 weeks and once a day for 4 weeks, and after 6 weeks his IOP becomes normal and there is a complete resolution of the nummular lesions. In previous studies, they have not compared the tacrolimus with the loteprednol eye drops. But there is successful resolution of the symptoms and signs with tacrolimus 0.03% eye drops. The purpose and methodology. The objective of this study is to assess the efficacy of tacrolimus 0.1% with loteprednol 0.5% in nummular keratitis caused by adenoviral keratoconjunctivitis. This prospective pilot study was done after taking approval from the Institutional Review Board. Total 100 cases of nummular keratitis was included in the study, and they are randomized into loteprednol group having 48 cases and tacrolimus 0.1% ointment group 52 cases. And all 100 cases were followed up at an interval of 1 week post randomization for 2 months and later monthly for 6 months, and objectively assessed both symptoms and reduction of clinical signs of keratitis. Inclusion criteria: patients with diagnosed case of nummular keratitis was included in this study, and patients with any signs of epithelial disease or infiltration and pregnant women were excluded from the study. Depending on the symptoms and symptom severity, we graded into 4 grades, and in tacrolimus group 32 cases had severe photophobia and glare and vision, 20 cases has moderate glare and vision, moderate glare with vision loss, and 10 moderate vision with loss. And after treatment, almost 42 cases there is complete resolution of the signs and symptoms. Only 10 cases had mild photophobia. In loteprednol group, 25 cases present with severe photophobia and vision loss, and 23 cases has moderate glare with vision loss. And after treatment, 34 cases are symptom free and 14 cases had mild photophobia. And we did the chi-square test, and statistical values are significant between the 2 groups. And these are the pre and post treatment pictures of the tacrolimus group, and there is complete resolution of the nummular lesions after successful treatment after 6 weeks of therapy. Coming to results and conclusion, among the 42 cases in the 52 cases in the tacrolimus group, 1 case was intolerant to tacrolimus and we shifted on to loteprednol, and 1 case had recurrence. In 48 of loteprednol group, and 7 cases had recurrent and 2 cases had rise in IOP, and we shifted them to tacrolimus group. So coming to conclusion, tacrolimus 0.1% eye ointment is used as a safe and alternative to steroids like loteprednol in the management of nummular keratitis, and this is useful especially in patients with steroid responders, but further larger studies are required to validate our results. These are my references. Thank you.
Did you include those 7 cases in this analysis? The cases of loteprednol recurrence and IOP increase, were they included in the analysis?
No, not included. And shifted them to tacrolimus, madam. Not included in them. 6 months, sir.
You are getting.
Yes, sir.
Those were your cases from your institute or referral cases?
Our institute only, sir.
You don't start on early steroid for all those cases.
Okay.
If you start on early steroid, you may not get So many nuclear keratitis, what I mean to say.
They presented with nummular keratitis only, sir.
Dr. Yashaswini Vamaravalli, a prospective study of visual outcome and stabilization of cornea with cross-linking in keratoconus.
Role of collagen cross-linking in progressive keratoconus. This is a prospective study. My aim of the study to evaluate the effectiveness of conventional collagen cross-linking procedure in progressive keratoconus patients. Objectives are to assess visual outcome, changes in astigmatism, simulated keratometry values, Kmax, spherical equivalent after collagen cross-linking in progressive keratoconus patients. It's a prospective study which is non-randomized, single-center clinical study. 30 eyes of 28 patients were incorporated into the study from June 2022 to March 2023. So inclusion criteria, patients of age 15 to 30 years with progressive keratoconus are taken into account with a central corneal thickness more than 400 microns. Exclusion criteria, age less than 15 years and more than 30 years are excluded, and patients with maximum keratometric readings more than 60 diopters and with central corneal thickness less than 400 microns. Any patients associated with any ocular surface disorders, apical corneal scarring, previous history of any thermal or chemical burns, any association with autoimmune diseases, pregnant and lactating mothers are excluded. Methodology, all patients are evaluated for subjective refractive correction, slit lamp examination, corneal topography. All patients who satisfied inclusion-exclusion criteria underwent collagen cross-linking under Dresden protocol under strict aseptic conditions. This is an overview of collagen cross-linking procedure. Under topical anesthesia, removal of corneal epithelium of 8 mm diameter with 20% alcohol. Corneal stroma was saturated with isotonic 0.1% riboflavin plus 20% dextrose solution, instilling 1 drop every 3 minutes for 30 minutes. Now stroma was exposed to UVA light of 370 nanometers at 3 milliwatts per centimeter square, with still continuing the installation of 1 drop of riboflavin solution every 3 minutes for 30 minutes. Centration of the eye should be maintained. After the procedure, cornea was thoroughly washed with BSS solution. Therapeutic bandage contact lens was applied at the end of the procedure. Post-operative medication and care, topical low-dose steroid drops were given in tapering doses. Topical antibiotic eye drops, topical lubricating eye drops. Post-operative care, dark goggles was advised to help from light, face hygiene and avoid rubbing of eyes. Follow-up, the patients reviewed on day 1 and day 3. Therapeutic bandage contact lens was removed after complete reepithelialization of the cornea. Further follow-up was done at 1, at 3 and 6 months. These are the results. An evaluation of 30 eyes in 28 patients with a mean age of 19.8 years. Males of 64% and female percentage was 36%. These are the topographic indicators compared preoperatively and postoperatively at 6-month follow-up, represented in mean plus or minus standard deviation. Preoperatively, the simulated K1 value is 46.8 plus or minus 2.8 diopters. When compared to post-op, it is 45.7 plus or minus 3.35, which is statistically significant. And simulated K2 value, it is 51.4 plus or minus 2.97 diopters. When compared to post-operative value, it is 50.09 plus or minus 3.03, which is statistically significant. And Kmax values, it is 56.1 plus or minus 2.74 preoperatively, and post-op 54.38 plus or minus 3.24. This is a bar diagram showing changes in K1, K2 and Kmax values. Best corrected visual acuity at the 6-month follow-up is 1 Snellen line improvement in 33.3% of eyes and 2 Snellen line improvement in 46.7% of eyes, and the visual acuity remains stable in 20% of eyes. Astigmatism decreased by the mean of 1.65 diopters and remains stable in 23.3% of eyes. Spherical equivalent decreased by the mean of 0.73 at the end of 6-month follow-up.
Kmax values are decreased by the mean of 1.67 diopters in 36.7% of eyes and 1.18 diopters in 43.3% of eyes, and remain stable in 20% of eyes. There is a decrease in corneal pachymetry by the mean of 469.26 microns to a mean of 385.26 microns. Complications are the immediate post-operative symptoms, which is redness, pain, watering, and mild photophobia, was seen in all cases, and there is mild stromal haze seen in all cases on post-operative day 1. There is a persistence of mild stromal haze was observed in 26.7% of eyes at the end of 6-month follow-up. Glare was complained by the patients with 33.3% of eyes. Sterile infiltrate was noted in one patient, that is 3.33%. At 1 week follow-up, which is healed with medication, and no reported cases of progression. Conclusion: the results shows stabilization of the cornea and improvement in visual outcome in progressive keratoconus patients after collagen cross-linking. This suggests that it is a safe and effective procedure. These are the few studies supporting my study. Bhattacharya et al. In 2019, he has taken 78 eyes divided into 2 groups, a control arm and the treatment arm, and there is a improvement in, and he was followed up for 1, 3 and 6 months, and there is a improvement in SIMK value, spherical equivalent, uncorrected visual acuity and best corrected visual acuity, which are statistically significant, and at the end of the 6th month in a treatment arm when compared to the control arm. And Parmod Guleria et al. In the study was done in 2017. C3R was done in 32 eyes of 21 patients with a mean age of 19.8 years. The preoperative values are compared with the postoperative values. After 6 months examination, there is an improvement of visual acuity, which is statistically significant.
Just one question. How did you calculate your sample size?
Sir?
How did you calculate your sample size?
Yes.
30 patients you have taken. So how did you calculate exactly?
Actually 28 patients, sir, 30 eyes. 30.
How you are calculating your sample size? Because you will publish this paper and the validity of the study.
Yes.
That we want to know. Like. Why I am asking you this question? This is a very simple question.
Yes.
They may ask you.
Yes.
There are formulas from where you have taken, what parameters you have taken to calculate a sample size. Because 30 patients, you cannot stamp that these things are happening.
Yes.
With 1.5 billion population, and you are writing a 30 people sample size. Check on it. How you calculate your sample size.
Actually, I'm having a formula for it, sir. We have taken a significant level with we have taken few statistical analysis studies of keratoconus, and in the significant level was taken up to 95%, and sigma values are also considered, sir. Actually, I'm not able to remember the formula. Yes, sir. Actually, we have calculated over the formula, sir. I can show you. Thank you.
Dr. Kumari Rachana, study on indications, complications and visual outcome in slit. Are you there?
Good morning everyone, I am Dr. Rachana, and today I will be talking about study on indications, complication and visual outcome in simple limbal epithelial transplantation. I have no financial disclosure. The human ocular surface serves the unique function of forming a resilient barrier to pathogens and environmental factors, and provides the metabolic requirements to the underlying stroma and maintain a smooth transparent optical surface. It is composed of 2 main tissues, that is the cornea and the conjunctiva, with limbus acting as a transition zone. The limbus is composed of radial fibrovascular ridges, the palisades of Vogt, that forms a niche for the corneal epithelial stem cells. Several insults, both intrinsic and extrinsic, can precipitate the destruction of these microenvironment of the stem cells niche, leading to limbal stem cell deficiency. The aims and objectives of my study is to study the various indications for SLET, to analyze the various complications, and to evaluate the visual outcome in patients of SLET. This was a prospective study conducted at a tertiary care hospital. A total of 12 patients fitting in the inclusion and exclusion criteria were selected from our routine OPD for this study, and the follow-up were done on day 1, day 7, day 14, 1 month, and then for 1 year each month. Patients with a documented history of chemical or thermal burns and with the presence of unilateral or bilateral limbal stem cell deficiencies were included, while patients with unknown cause of LSCD, patients with untreated concurrent ocular problems such as entropion, trichiasis, etc., and the patients with cases of LSCD occurring after ocular surface tumor excision and radiotherapy for intraocular tumors or without visual potentials, that is for cosmetic correction, and patients not willing for the procedures were excluded. Post-operative assessment were done on the basis of Snellen's visual acuity, ocular digital pressure, staining by fluorescence, Shermer test, and any complications that were present after surgery. So coming on to observations and results, out of the total 12 patients, 84% were male and only 16%, that is 2 patients, were female. And in every age group, the more number of males present than females. Maximum number of patients that came to our hospital were in the age group of 20 to 40 years. The patients who came to our institution that has the indication of SLET, among them, majority of them has the indication that is because of the injury due to liquid acid burn, that is 5 patients, and only 1 patient had the indication that is dry eye and injury due to plant juice. And the most common pre or baseline finding that is that we found on SLE was epithelial defect that was present in all 12 patients, and 10 patients were having conjunctivalization and corneal vascularization, and only 4 patients has had symblepharon. Visual outcome, the pre-op visual acuity of these patients that is being shown in this pie chart. 50% of the patients has the visual acuity of hand movement to finger count close to face, and 17% has the visual acuity less than 6/60. The average post-op visual acuity after 1 year of follow-up was as we can see in this pie chart. 58% has visual acuity more than 6/18, which shows that there has been a improvement in the visual acuity, and only 17% has less than 6/60. This is the tabulated form of the complication that were encountered at the end of 3 months and 6 months of follow-up. We can see that there are more complications seen at the end of 3 months, among which keratitis and dry eye was the most common complication seen in 3 patients, that is of 25%, and at the end of 6 months dry eye was seen only in 2 patients, and rest all the complications were also less. So to conclude, after the 6 months of follow-up of our cases, we see that an excellent result with improvement in visual acuity as well as stabilization of ocular surface. We can see a few pictures from our study that the patients preoperatively has a vision of 1 meter finger count has been improved to 5 meter finger count and to 6/18. And these are 2 more pictures which showing an improvement of from 2 meter to 6/24 and 4 meter to 6/18. So to conclude, autologous SLET can be a successful method in restoring the ocular surface as well as improving vision. Thank you.
Actually, 9 of your patients already had a poor Shermer's to begin with.
Yeah.
So, and you've shown that as a complication at 3 months. So I don't think that can be included. Maybe 1 case of keratitis you can mention, but.
And what about those patients who have severe dry eyes? What you did about those patients? 2 cases.
Sir, we prescribe them with lubricating eye drops to control, to maintain their ocular surface.
Do you think it will improve, or you need to do a mucous membrane grafting?
So we can go for mucous membrane grafting or autologous grafting.
Thank you, sir. Dr. Kumari Rachna, study on, Dr. Mosam Mohanty, role of specular microscopy in toxic endothelitis due to latex of Calotropis procera.
Good morning everyone. My topic is role of specular microscopy in toxic endothelitis due to latex of Calotropis procera. I have no financial interest. So Calotropis procera is a flowering shrub which is commonly used to worship Lord Shiva, which profusely exudes out thick milky latex on plucking its flower. Accidental eye contact with its latex induces endothelial inflammation leading to variation of endothelial parameters. Speculomicroscopy is a non-invasive tool to assess the corneal endothelium characteristics. Documenting the endothelial changes in these patients is crucial, as if not treated on time may cause significant ocular morbidity. My aim is to study the endothelial changes in patients with toxic endothelitis caused by Calotropis latex using speculomicroscopy. This is a prospective observational study for a period of 6 months. A series of 15 patients were taken with history of Calotropis latex exposure and diminution of vision. They were clinically examined as per standard procedure, and speculomicroscopy was done on day 1, day 7, 1 month and 3 months. Parameters assessed were endothelial cell density, hexagonality, coefficient of variation, and central corneal thickness. My first case was a 33-year-old female who presented with redness of right eye, photophobia, and diminution of vision. On presentation, visual acuity in right eye was 6/60 and slit lamp revealed mild conjunctival congestion with corneal edema with descending membrane folds. IOP in both eyes were normal. On treatment with topical steroids, visual acuity improved to 6/6 in 2 days. This is the day 1 speculomicroscopy finding. As we can see that none of the parameters could be assessed except CCT, which was found to be raised in comparison to normal eye. On follow-up, the cell count was found to be in normal range, whereas the other parameters revealed polymegathism and pleomorphism. As we can see on day 30, there was no reduction in endothelial cell count. Coming to case 2, 66-year-old male, known hypertensive, presented with redness of right eye with painless diminution of vision. His best corrected visual acuity was counting finger 1 meter in right eye and 6/24 in left eye. Slit lamp examination showed right eye seen to have conjunctival congestion and no epithelial defect, corneal edema with descending membrane folds. Nucleus sclerosis of the lens and hazy view of the fundus was seen in both eyes. IOP was normal in both eyes. This is the day 1 presentation when descending membrane folds were seen, and this is the post-treatment with 1 week steroid treatment. On day 1 of speculomicroscopy, the CCT was found to be raised in comparison to normal fellow eye. On follow-up, the cell count was seen to be within normal range after 1 week of treatment with steroids. The other parameters revealed some degree of pleomorphism and polymegathism, and after 3 months of follow-up, the cell density was not reduced. 15 such cases were examined. And this is the demographic profile of all my patients. 60% females were affected, 40% male. Right eye was more affected than the left eye. This is the clinical profile. Visual acuity was 27% less than 6/60 and 53% in 6/60 to 6/18 vision, and 20% patients had a vision of 6/18 to 6/12. My speculomicroscopy parameters, the cell density after 1 week of treatment was found to be more than 2000 in all cases after 7 days, and there was polymegathism and pleomorphism seen in all cases. Post-exposure corneal thickness on day 1, 20% cases had a range of 500 to 600, 60% case had a CCT range of 600 to 700, and 20% cases had a range of more than 700. After 3 months of follow-up and 1 week of steroid treatment, 73.4% cases had a CCT range of 500 to 600. So, all my patients were age ranging from 33 to 78 years presented within 24 hours of exposure. Females were more affected as against male preponderance. In other study, right eye was more affected. There were absence of pain, and all patients had stromal edema with descending membrane folds. My study, in comparison to other studies, Al-Mazin, in his study presented that permanent endothelial loss was seen in speculomicroscopy after 3 months. Bassak revealed low endothelial count in 74 cases. Weckers revealed increased corneal thickness, low endothelial cell count, polymegathism and pleomorphism. But in my study, there was no significant difference in cell count. There was polymegathism and pleomorphism and increased CCT in 13% cases. So to conclude, speculomicroscopy is a valuable non-invasive tool for monitoring both qualitative and quantitative endothelial changes in toxic endothelitis. Clinico-specular correlation helps in making an accurate diagnosis of the condition, assessing the functional reserve of the cornea and prognosticate the disease. These are my references. Thank you.
Question: do you think the amount of latex will, the outcome of your study will change?
Amount of latex?
Latex, what is going into the eye?
The thing is that the latex, all my patients were actually females mostly and retired individuals who were plucking those flowers to worship God. So even a small amount, they said that when they have plucked and accidentally they had touched their eye, then this diminution of vision happened, which was so profound that they had to present. So amount of latex I didn't inquire. There are other studies also on this topic.
So you are saying comparison between the other eye specular and the 3-month outcome is
Yes.
not significant.
No, because the other study showed that comparatively there were low endothelial counts
Compared to what?
compared to the normal eye, fellow eye. But in my case, because all the patient presented within 24 hours, so immediate intervention, immediate diagnosis, and also follow up with specular microscopy, I could assess that if patient are aware of this, then they can easily get treated and this significant ocular morbidity can be prevented.
No, I'm just asking statistical calculation. You said there was no significant difference in your specular counts
Yes.
at the end of the follow-up.
Yes.
That was between the normal eye and
Yes,
this
yes,
eye.
yes. Thank you.
Dr. Sukanya Padi. Comparison between sodium hyaluronate and CMC eye drops in treating dry eye.
Good morning everyone. Today I'll be speaking on the topic comparison between sodium hyaluronate and carboxymethylcellulose eye drop in treating dry eye disease. I have no financial disclosure. Dry eye presents with pain, ocular discomfort, limited vision, impacts the quality of life. Dry eye can be divided into aqueous deficient and evaporative disease. Aqueous is further divided into Sjogren's and non-Sjogren's, which is Sjogren's has primary and secondary causes. Non-Sjogren's has lacrimal deficiency, lacrimal gland duct obstruction, reflex block, systemic drugs. And evaporative has intrinsic and extrinsic causes. In intrinsic, we have meibomian oil deficiency, disorders of lid aperture, low blink rate, drug action like Accutane. Extrinsic causes has vitamin A deficiency, topical drug preservatives, contact lens wear, ocular surface disease like allergies. Observational study was carried out during a period of 5 months from March to August 2023 in our tertiary care hospital, comprised of 40 patients randomly allotted to receive 0.1% sodium hyaluronate and 0.5% CMC eye drops 3 to 4 times a day for an 8-week period. TBUT Schirmer's test without anesthesia and dry eye symptom score found using the ocular surface disease index were assessed at baseline and 4 months and 4 weeks and 8 weeks of treatment. Carboxymethylcellulose is an anionic polymer of glucopyranate subunits which helps in water retention and has moistening properties. Sodium hyaluronate is a glycosaminoglycan found in vitreous and tears and has the ability to tether water molecules and avoid tear film desiccation. Study approved by our hospital ethics committee, informed consent obtained from the participants. Patients with symptomatic dry eye disease with OSDI score more than 13 were in the inclusion criteria. Prior refractive surgery, active ocular infection, contact lens wearers, use of any ocular medications within 14 days of study enrollment were in the exclusion criteria. 40 randomly allotted patients, of which 17 patients were male, 23 patients were female. TBUT less than 10 seconds into evaporative group, which has computer vision syndrome. Schirmer value less than 10 mm into aqueous deficient group. Alter TBUT and Schirmer's test were considered in the combined dry eye disease. TBUT is done using fluorescent impregnated strip. Dry is distributed by blinking was then observed under cobalt blue filter. Time interval between last blink and development of first dry spot was taken. Normal value being more than 10 seconds, anything less was considered as dry eye disease. Schirmer test was done using Wortmann filter paper of 41. This was done without using any topical anesthesia. Value less than 10 mm was taken as abnormal. CMC group had 9, as a result, CMC group had 9 males and 11 females, and sodium hyaluronate group had 8 males and 12 females. The participants had a mean age of 42.63 years and CMC had 45.67 years in sodium hyaluronate group. This is the data we have collected over a 5-month period. Evaporative dry eye disease had 15 patients in total. Aqueous deficient group had 13 patients in total. Combined dry eye disease had 12 patients in total. This is the total data we have collected over the 5 months period. And we can clearly see the graphical presentation that in CMC group, the OSDI score is decreasing and TBUT and Schirmer test results were increasing. And sodium hyaluronate had superior decrease in value of OSDI score. And sodium hydroxide group demonstrated slightly higher increase in TBUT values than the CMC group. Though literature stresses on the anionic nature of the CMC and its effectiveness on tear retention time, the contradictory result in a study can be because of the greater epithelial repair and greater viscosity of sodium hydroxide. Limitations of our study are its short duration of 8 weeks, which was inadequate to assess the changes in conjunctival cytology. Commercially available SH used in the study had, in addition to 0.1% SH, glycerin as an aqueous buffer, which might have modified the results. Using Shermer's test and TBUT was the lack of standardization with low reproducibility. SH, to conclude my study, SH and CMC are equally effective in treating mild to moderate dry eye disease, with greater improvement observed in terms of subjective symptoms of SH. Both SH and CMC improved the objective parameters for dry eye disease over the 8-week treatment course, with better outcome obtained for sodium hydroxide. Thank you. These are my references.
Complete erosion, staining pattern. Complete epithelial erosions were noted.
Yes, ma'am. But I'm not included in the study because there were no sufficient
Measure?
No, actually there were no sufficient data for the study over the 5 months period. Thank you.
Is the first speaker here? Ram Kumar Jaiswal is absent. Thank you very much for a wonderful session. I thank chairperson, co-chairperson and convener, sir. Results will be announced by the scientific committee.